بسم الله الرحمن الرحيم. الحمد لله رب العالمين، والصلاة والسلام على أشرف المرسلين سيدنا محمد وعلى آله وصحبه وسلم أجمعين. سبحانك لا علم لنا إلا ما علمتنا إنك أنت العليم الحكيم. Dear colleagues, this is the second part of the imaging of the shoulder. We have finished in the first part the examination technique and the anatomic details. Now we are going to discuss the evaluation of the rotator cuff injuries as well as the impingement syndrome. Then in the third part of this of the imaging of the shoulder, we will discuss instability and slap injuries. Then you know that the rotator cuff is formed of four muscles, which are the supraspinatus, infraspinatus, teres minor, located along the posterior aspect of the scapula, supraspinatus, infraspinatus, teres minor, and these muscles insert into the greater tuberosity. A muscle which is located anteriorly is the subscapularis, which inserts into the lesser tuberosity. Actually, the biceps tendon is not included in the rotator cuff tendons, but it plays an important role in stability and movement of the shoulder joint. We'll start by the first and the most important muscle and tendon, which are the supraspinatus muscle and tendon. And you know, the supraspinatus tendon is identified by detection of the acromioclavicular joint in the coronal images. Then you look inferior to the joint and you see the muscle. Then you see the tendon, which will insert into the greater tuberosity. Normally, the tendons will appear black or low signal in the T1 and also in the T2 weighted images. This is the normal appearance of the tendons in general. And here you can see this is the supraspinatus muscle and this is the tendon inserting into the greater tuberosity. This is an MR arthrogram showing the appearance of the normal supraspinatus tendon inserting into the greater tuberosity. Then we have the abnormalities in the tendon, and the first is the detection of an intermediate signal within the tendon substance which is not seen in T2 weighted images, and this is considered normal. You may, on examination of the shoulder, you may identify, and this is the frequent finding, of course, an intermediate signals within the supraspinatus tendon, but in the T2 weighted images, you can notice that the tendon is normal. And there are many explanations for this finding, including that the muscle slip is prominent, the fat plane between the two slabs of the supraspinatus muscle, and also the magic angle technique, which is a tendon going through about 55 degrees to the static magnetic field, and this phenomena is appreciated in the peroneus longus tendon in the ankle and also here in the supraspinatus tendon in the shoulder. Then starting abnormalities, whenever you can detect an intermediate signal in the T1 and also intermediate signal in the T2 weighted images. This means that the tendon is degenerated, and we call this tendon degeneration or tendinopathy or tendinosis. And many times in this category, you can see that the supraspinatus tendon is considerably swollen, as you can see here. And this is the normal thickness of the tendon, which ranges from 2 to 4 millimeter, but here you can appreciate the considerable thickening of the tendon. Then whenever you see an intermediate signal within the tendon in the T1 and also in the T2 weighted images, you know that this is tendon degeneration, tendinopathy, or tendinosis. And this may be associated with swelling of the tendon and may not. And this is also an example of tendinopathy. You see the supraspinatus tendon showing intermediate signal in the T1 and also intermediate signal in the T2, and this is diagnostic of tendon degeneration. Another example of tendon degeneration is the heterogeneous intermediate signal within the tendon in the T1 and also in the T2 weighted images, diagnostic of tendon degeneration. As you remember that one of the common lesions that are associated or contributing to the degeneration of the tendon is the acromion shape, particularly the type 3 with anterior hook. And you remember that the acromion shape is evaluated in the sagittal images, and here you can see an anterior hook type 3 acromion with tendinopathy of the supraspinatus tendon, showing intermediate signal in the T1 and also in the T2 weighted images. And here also you can see some osteoarthritic changes in the acromioclavicular joint with intermediate signal within the tendon and also intermediate signal within the tendon in the T2 weighted image, denoting tendinopathy and tendon degeneration. In this particular example, you can appreciate that the supraspinatus muscle is relatively atrophic, and you can identify also linear fat signals within the muscle, and you can know the cause. And you see that this patient is old, and in old age you may see or notice some of the atrophic changes in all the muscles of the shoulder girdle. And this is supraspinatus tendinopathy T1 and T2. The supraspinatus tendon is markedly swollen. It shows intermediate signal in the T1 and also intermediate signal in the T2 weighted image. And if you look carefully, and you can see this bright signal within the tendon which indicates tear, and in the presence of intermediate signal denotes degeneration, while the bright signal in the T2 weighted image is usually an indication of tear. Then you know that by time degeneration will proceed to tendon tear. First partial tear, then complete rupture of the tendon. And this is the start of the development of tear within the substance of the degenerated supraspinatus tendon. Then, considering the supraspinatus tears, we have two types, the partial tear and full thickness tear. Partial tear is also divided into three subtypes. The tear affecting the surface of the tendon facing the joint, and this is known as articular surface tear. And the tear in the surface of the tendon facing the bursa, and this is known as bursal surface tear. And the third one is a tear inside the substance of the tendon, not reaching the superior nor the inferior surfaces of the tendon. And here is an articular surface tear which is clearly identified by MR arthrogram. This is the supraspinatus tendon, and you can see this fine tear in the surface of the tendon facing the joint. This is partial articular surface tear. And in this example, you can see that this is the supraspinatus muscle and tendon. You can identify that the superior fibers of the tendon are intact, reaching the insertion site in the greater tuberosity, while the inferior fibers are not intact, they are disrupted here, and you can appreciate the fluid signal, denoting there is partial tear in the surface of the tendon facing the joint. This is also an example. This is the supraspinatus muscle and the tendon, and you can see this tear in the articular surface. The bursal surface of the tendon is intact. Then bursal tear affects the surface of the tendon facing the subacromion subdeltoid bursa. And look in this example, this is the acromioclavicular joint. This is the supraspinatus muscle and the tendon. The inferior fibers are intact, reaching the greater tuberosity. The superior fibers are disrupted here with fluid signal, diagnostic of partial bursal surface tear. An intrasubstance tear is that one affects the interstitial part of the tendon without disrupting any of its surfaces. And here is an example. This is the supraspinatus muscle and this is the tendon. And here you can see the tear within the substance of the tendon itself. And this is also another example. And you see the superior fibers are intact and also the inferior fibers are intact while the tear is inside the substance of the tendon itself. Then, as I have said, you can see here that this is tendinopathy with intermediate signal in the T1 and also intermediate signal in the T2. But in the T2 weighted images, you can see fluid signal near the insertion site of the tendon, denoting that this tendinopathy is complicated by developing tear in the supraspinatus tendon. Then in cases of full thickness tear of the tendon, there is complete rupture of the tendon with sometimes a gap between the cut edges of the tendon. And there may be retraction of the muscle and also atrophic changes in the muscle itself. All these information are very important for the clinician in order to decide whether he is going to repair this tendon or not. Then this is the acromioclavicular joint and this is the supraspinatus tendon, which is ruptured here, and you can see the gap between the cut edges of the tendon, and in every case there is a full thickness tear of the supraspinatus tendon. You should measure the gap between the cut edges of the tendon. And here you can see this is the supraspinatus muscle and this is the tendon which is torn here, and this is the gap between the cut edges of the tendon. It's very important to mention this clearly in the report. What is the length of the gap between the cut edges of the tendon, and what about the state of the supraspinatus muscle? Is it atrophic or is still maintaining its bulk? Like in this case, the muscle is good. Then this is the full thickness tear of the supraspinatus tendon. You see the cut edges, and this is the gap, which may be in the range of a few millimeters. Then you look for the muscle, and the muscle is good because the muscle bulk is maintained, and you cannot see the linear high signal fat within the muscle. These linear high signals are considered within normal, but whenever the muscle is atrophic, I will show you an example. And here is extensive osteoarthritic changes of the acromioclavicular joint with rupture of the supraspinatus tendon, and you see the cut edge is from here to there. This gap is about 2 centimeters, for example, and you look to the muscle and the muscle is intact. I would like to mention here that the myotendinous junction, which is the junction between the muscle and tendon, usually contains fat, and this area is not an area to be evaluated for tears. The tears are evaluated in the tendon itself, not in the myotendinous junction or in the muscle itself, but you evaluate supraspinatus tendon tears in the tendon itself. Then this is the full thickness tear. You can see the cut edge of the tendon. Here is the cut edge of the tendon, and this is the gap to the greater tuberosity. The gap is about 2 centimeters, and the muscle is more or less intact. Then this is also a full thickness tear. You see the cut edge of the tendon and the retraction of the muscle, and there is very big gap between the cut edge and the insertion site. And also you can appreciate the evident atrophic changes in the muscle because of the linear high signal fatty changes within the muscle denoting atrophy. Also you can appreciate the considerable amount of joint effusion. And in cases of full thickness tear, and the presence of joint effusion. Effusion is now freely has the free access to the subacromial bursa, and you cannot consider this as bursitis because the fluid in the bursa is not secondary to inflammation. It is secondary to rupture of the supraspinatus tendon, allowing the joint effusion to get into the or to communicate with the the subacromial bursa. And you know that osteoarthritis of the acromioclavicular joint is one of the major causes contributing to degeneration and tear of the supraspinatus tendon, and this is an example of advanced osteoarthritis of the acromioclavicular joint with full thickness tear of the supraspinatus tendon. You see the retraction and the distance from the cut edge of the tendon to the insertion site. And also you can appreciate that the muscle bulk is more or less maintained. And this is an important issue reported in the literature, that about 34% of asymptomatic individuals may have rotator cuff tears, and this incidence will increase by age. And you can see here the most common cause, which is acromioclavicular osteoarthritis with callus formation impinging on the subacromial tunnel, then causing so much difficulties for the movement of the supraspinatus tendon, which will start degeneration followed by tear. And here you can see a full thickness tear of the supraspinatus tendon. You can see that there is a big gap about 2 to 2.5 centimeter with some atrophic changes in the muscle. Then if there is calcium within the supraspinatus tendon, and this is known as calcific tendonitis, then calcium is best appreciated by the plain X-ray and the reformatted CT images, and is somewhat difficult to be identified in MRI, because you know that calcium will show low signal in all pulse sequences, and also the tendon normally show low signal in all pulse sequences. And this is the normal supraspinatus tendon, which is of uniform caliber and regular outline. But whenever calcium is deposited in the tendon, it will also show low signal in MR images, but you can appreciate that the tendon is not of regular thickness or outline. You see the abnormal contour of the tendon and the irregularity of the margin. And whenever you are suspecting calcific tendonitis in MR images, it's better to have the plain X-ray for this shoulder. Then you can appreciate very easily the presence of calcium within the supraspinatus tendon along its course to the greater tuberosity. And this is also calcific tendonitis seen by MRI. This is the supraspinatus muscle, and this is the tendon, and you can see that the tendon is not of regular contour or caliber, and it shows heterogeneous low signal in the MR images, and this is an indication of calcific tendonitis. Then we finished with the supraspinatus and we came to the infraspinatus. You remember that the infraspinatus tendon is best evaluated in the axial images, and here the subscapularis tendon inserting into the lesser tuberosity, and this is the supraspinatus tendon which is inserting into the greater tuberosity, and this is the bicipital groove where the biceps tendon is present. Also, you can identify the infraspinatus tendon in the coronal images at the level of the spine of the scapula, and you can know that this is the spine of the scapula by the characteristic inferior protrusion. Then you see this infraspinatus tendon inserting into the greater tuberosity. You can also evaluate the muscle bulk in the axial images and in the sagittal images. You remember, this is the supraspinatus muscle, infraspinatus teres minor, and this is the subscapularis. Then ruptures of the infraspinatus tendon are better evaluated in the axial images. Here you can see the subscapularis tendon and the muscle, and you can appreciate the high signal appearance of the infraspinatus muscle. And in the sagittal images, this is the spine of the scapula, and this is the infraspinatus tendon, which is torn here. And you can also see the gap between the cut edge of the tendon and the insertion site in the greater tuberosity. In this example, you can see heterogeneous high signal intensity within the muscle, and you confirm that this muscle is the infraspinatus in the axial images, and you see the heterogeneous laceration and edema of the muscle in the axial images affecting the infraspinatus tendon, the infraspinatus muscle. And this is the spine of the scapula. As you can see, the inferior protrusion. Then this tendon will be the infraspinatus tendon, and you can see the rupture of the tendon at this side. And it's written in the books that if you are able to have this position, which is known upper or abduction external rotation, and this can be obtained by the patient whenever you are examining him in an open magnet, then you can appreciate the the injuries of the infraspinatus as well as the supraspinatus tendon, which will appear clear enough in this particular position. We came to the subscapularis, and the subscapularis tendon is best appreciated in the axial images, and it is always stretched between the muscle and the lesser tuberosity. And also you remember the subscapularis tendon is seen in the coronal images whenever you identify the coracoid process and the tendon is broad, it will insert into the lesser tuberosity. Also, you can appreciate the subscapularis muscle in the sagittal images. You know that this is the coracoid process, which is facing anteriorly. Then this will be the subscapularis muscle, and this is supraspinatus, infraspinatus, and the teres minor. Ruptures of the subscapularis tendon are uncommon, and this tendon is very strong and needs a strong force to rupture. Then to diagnose rupture of the tendon, you can see that the tendon is not stretched, it has a wavy course and is not reaching the insertion site in the lesser tuberosity. Then you know that the subscapularis tendon is intimately related to the tendon of the long head of the biceps in the bicipital groove, and many times the subscapularis tendon ruptures, it will affect the tendon of the long head of the biceps, as you see in this example. This is the subscapularis tendon, which is torn and is not reaching the insertion site in the lesser tuberosity, and this is the biceps tendon, which should be here in the bicipital groove, but because of the rupture of the subscapularis tendon, the biceps tendon is now dislocated outside the groove. And this is also another example, and I recommend to evaluate biceps tendon abnormalities in the axial image, looking at the tendon within the groove. It's relatively difficult to evaluate the dislocation or subluxation of the tendon in the coronal images. And this is the subscapularis tendon, and this is the biceps tendon, of course, which should be here. It has been dislocated outside the groove. And in this example, you can see the cut edge of the subscapularis tendon and the gap between the tendon and the insertion site in the lesser tuberosity. Then sometimes you are confronted by an example like this one, where the distance between the coracoid process and the head of the humerus is relatively narrowed. And the normal distance between the coracoid and the humerus is from 8 to 11 millimeter. And if the distance, like in this example, is about 4.5 millimeters, then you got what's known as subcoracoid impingement. And subcoracoid impingement, of course, will affect the subscapularis tendon, which is crossing here. Then you may notice degeneration of the tendon or even ruptures of the subscapularis tendon. Then the diagnosis of coraco or subcoracoid impingement is or depends on the measurements of the distance between the coracoid and the humeral head. If it is smaller than 8 millimeter, then you consider this. And as I have mentioned, if you look carefully to the subscapularis tendon, it may be normal, but sometimes you got degenerative changes and even tears of the tendon itself. Then we came to the impingement syndrome, and this impingement syndrome means that the supraspinatus tendon moving into its tunnel is facing some difficulties because some encroachments on this tunnel by either osseous abnormalities or soft tissue abnormalities. Then the end result is narrowing of the tunnel, and this will hinder the normal movement of the supraspinatus tendon. Then the tendon will degenerate, and finally it will be torn. Then the osseous abnormalities contributing to impingement syndrome include the acromion shape. You remember type 3 and type 4 are one of the causes of compromise of the subacromion tunnel. Also, the presence of os acromial and the osteoarthritic changes of the acromioclavicular joint. The acromioclavicular joint is seen in the coronal images, and you can see here. You remember this acromioclavicular joint is the anatomic landmark for the supraspinatus tendon. Also, it is seen in the sagittal images, and you can identify the supraspinatus muscle underneath the joint. And in the axial images, sometimes you can see the acromioclavicular joint. This is the acromion, and this is the clavicule. Then the acromion shapes, as you remember, they are four: two normal and two abnormal. The normal acromion shapes include the acromion with flat undersurface and the acromion with concave undersurface. These are the normal acromion shapes. And the type 3 is the acromion with anterior inferior hook, and this is the dangerous one, contributing to degeneration and tears of the supraspinatus tendon. And the least common type, which is acromion with convex inferior or convex undersurface. And this is type 3 acromion with anterior hook, and this is type 4 acromion with concave undersurface. Acromioclavicular osteoarthritis will result in degenerative narrowing of the joint, osteophytic clipping of the articular surfaces, and hypertrophy of the articular margins, forming what is known as callus around the joint. And the callus around the joint will extend subcutaneously and also will involve the subacromion area and encroaching on the supraspinatus tendon. And this is an example of acromioclavicular osteoarthritis with callus formation in the coronal image and in the axial image. You can see the pseudocystic changes in the subarticular areas. And this is an advanced case of acromioclavicular osteoarthritis. You see the extensive callus formation around the articular margins of the joint. Then this callus is impinging and encroaching on the subacromion tunnel with resultant full thickness tear of the supraspinatus tendon, as you can see. And this is extensive callus formation at the acromioclavicular joint, impinging on the subacromion tunnel with consequent tendinopathy of the supraspinatus tendon, which is swollen, showing intermediate segment. Then The bursa around the shoulder joint are three, and you remember the subacromion subdeltoid bursa, the subscapularis bursa, and the subcoracoid bursa. The subacromion bursa is located underneath the acromion, and it will extend underneath the deltoid, hence its name, subacromion subdeltoid bursa. And you know that fluid will accumulate in the bursa whenever it is inflamed, and this is known as bursitis, which can be seen in cases of rheumatoid arthritis, gout, TB, and other types of inflammatory lesions. And you see here fluid in the subacromial bursa above the supraspinatus tendon, and this fluid is extending underneath the deltoid muscle, as you can see here. Then the one thing to be mentioned here, if you see there is full thickness tear of the supraspinatus tendon, and you can detect the fluid in the subacromial bursa, you know that this fluid is not secondary to bursitis, but it is the extension of joint effusion into the subacromial bursa secondary to rupture of the supraspinatus tendon. Then if the supraspinatus tendon is intact, consider subacromial bursitis. If the tendon is full thickness torn, consider that the fluid is coming from the joint. And this is an example of subacromial subdeltoid bursitis in the axial image. This is the deltoid muscle, and you can see this fluid signal underneath the deltoid muscle, and it is of low signal in the T1 weighted images, denoting bursitis. Then if the tendon is intact, like in this case, or if it is degenerated or partially torn, and you can see fluid in the subacromial bursa, and this is secondary to bursitis. It is only in case of complete rupture of the tendon, whenever you see fluid in the subacromial bursa, you consider it coming from the joint. Then the subcoracoid bursa, you remember that this area is known as the superior subscapularis recess, and this recess is continuous with the joint, meaning that if the joint is containing fluid, then this recess will also accumulate fluid. But the subcoracoid bursa is present outside the subscapularis muscle, and you remember this drawing, and you can see the coracoid process. Underneath the coracoid is the superior subscapularis recess, and this recess is continuous with the joint. It will fill with fluid if the joint is containing fluid. Then outside the subscapularis, you can see the subcoracoid bursa here, and underneath the subscapularis you can identify the subscapularis bursa. And I thank you very much. Walhamdulillah Rabbil Alameen.